Can you see me?
Yeah, I can see you. They'll control from here. Don't worry, Anand.
Yeah, that's fine. Thank you.
Yeah. Okay,
Firstly,
go ahead.
sincere thanks to all of you for this fantastic opportunity, Dr. Srinivas Kumar and everybody else. I'll just go through this very quickly and show the next slide, please. Yeah, next. So this was a double valve in valve case with micro TPS. Next one, please. For the purpose of time, I'll skip this one. Next one. Next. 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 So that's aortic valve in valve deployed. That's a mitral valve in valve deployed. That is with the CT fusion image. And next, this patient also had a significant heart block. So a micro was done next. So these are the things that can be done in this day and age for this very sick patient. His EF was 15%. Now it is almost 50%. And he's doing absolutely fine. This is more than a year ago. We'll go to the main case. Next slide, please. So this case we are going to discuss today is a 85-year-old syncope, semi-conscious, multiple comorbidities, and complete heart block, initial hemodynamic issues and metabolic issues corrected. And after detailed discussion, this is a perfect patient for the MICRA. So I'll just run through this. Just start the live inbox, please.
We got a very normal way mentor, one program is deployed, and wire is there. On the right, we got a TPI
ready to support him. So we are going to open the micro, and this end will show you the preparation of the micro, and then we'll just go ahead with the procedure. So this kit comes with sheath and wire as well as the system, the micro system. So yeah, this is all comes as one package. So the sheath is already prepared and is flushed it. The wire is there. We can open the micro.
Yeah. So this is the Medtronic sheath. This outer diameter is 27 French and the inner diameter is 23 French. So this is a 56 centimeter sheath, and through which we will be taking the MDS system, the micro delivery catheter system, into this, for which we would first need to put a stiff Amplas super stiff wire into the right side of the heart, and then we will position this sheath within the right atrium.
Now you have got two types of leadless pacemaker. One is the VR, it is a single chamber one, and the AV is a dual chamber one. The sensing of the atrial activity is completely different to the normal pacemaker sensing. Normal pacemaker sensing, you have a lead which senses, and accordingly the ventricular lead spaces. Here the sensing is done by a special sensor which is at the end of the leadless pacemaker. So it senses the atrial activity, and according to the atrial activity it will coordinate and pace the ventricle. So this middle one, it is to flex the catheter. So once we are in the right atrium, this will be used to flex. So it will flex it. Now the top one, obviously it is for delivering the system, and this one is the tether release. The green is the tether release. We will be releasing that once the system is inside. Okay, now we need a good flush in this.
So this step is important before having the
keep it up
MDS system in. So what we are using is a 25 ml syringe with saline with a lower lock, and we are preparing the MDS, the catheter system. As you can see, we are trying to flush out all the air, and as I flush out all the air, Dr.R Anantharaman has pulled the leadless pacemaker into the sheath, and I close the system there. And now the system is ready to be taken into the sheath.
So it's as simple as that. Preparation, there is not much. Basically a good flush, and then the system is pulled back in. It's like any other devices, like ASD devices. System is ready to go in. So what we are going to do is, we will put a JR4, exchange that wire to a stiff wire, and then we will put this sheath, 23 French sheath, then we will be going ahead with the delivery. Good.
Three-way.
Hold the wire. Okay, give the stiff wire. Alagampa. Yeah. Okay, okay, the stiff wire is there. Good. So we're putting a 12 first, and then a 14 first, and then an 18 dilator. That should be enough. Then we'll be taking the 23. Groin kamipa. Show the groin. So it's going freely, you can see. Okay. Keep the wire in. Okay, give the next one. 14. Show the groin. Yeah, so that's nice and free. Give the 18. Good. So now this is the 18. Yeah, it's going free. Okay, give the sheath. So for all transcatheter procedures, including TAVIs and mitral, everything we use this. Mela coming.
Contrast
Avladhan.
contrast or bowl.
Yeah, that's fine.
So the wire is in the SVC.
Yeah.
And you're leaving it in the mid RA.
So it should be fine.
Yes.
So this is the TAVI method. All wires, these two fingers will push the wire, this will come out. So you never lose the wire. Okay, good.
Yeah.
Cut பண்ணிடலாம். Okay. So anything we put in the right atrium, obviously we do this for all devices. You do a continuous flush.
Open.
Yeah. Good. Fluoropa. Show it from the abdomen. So now the system is in the right atrium. I'm just, you see there is a radiopaque marker in the sheath and there is another distal marker in the device. So I'm just going to bring those together. So now it is in the right atrium. Now obviously I will be pulling the sheath back so that the device is in the right atrium on its own. So if you watch, the sheath is coming out. Now the device is there. So this will give me, I'll just bring it below the IVC, about there, so that I can flex the device. Otherwise it will not be possible to flex. Now the device is on its own in the right atrium. The next step, if you watch, obviously as I showed earlier on, this grey handle is the one that will flex the device. So it is gone in. Store that. Then you can release the flex. You don't need that. So basically when it goes in, more or less it goes towards the apex and towards the septum. So we can come to another view. So it is facing posterior. It is in a perfect position. What do you think, Deepak?
Yeah, little more push on the.
Push, yeah.
Little more push, little more swan neck. Yeah,
There-
looks good.
Come to RAO. Now here again you can see it. Now here I am going to take one contrast image. You should see the contrast going up and down. That means you are in a perfect part of the septum. So Deepak is going to inject. 1 second. Inject please.
Yes, no, okay.
Okay.
Yeah.
Yeah, that's good. So you can see
Yeah,
the
level.
trabeculation in the right ventricle, and you can see the contrast going up and down. So that means you are not in the apex, you are somewhere in the lower 1/3 of the septum. That's where I want it to be. Go to LAO please. We'll do one more picture in LAO. Yeah, I'm perfectly happy with that.
Yeah.
It's in a good position. You can see the nice trabeculation. It's perfect. So I'll ask Deepak to release that.
Yeah.
Yeah, perfect. So the green tether button is unlocked. Now we are fine. we have a good contact. So with the left hand you keep a good contact, with the right hand you plunge it. So that's the usual technique, and that's what Deepak is doing. He's done a few of this, so will not be having any issues. Yeah, so you see the prongs have come out.
This is, so I have pushed it halfway, midway through, and now I have taken my pressure off the sheath, and then now I release it till I hear the click. Yes.
Yeah. Now if you come to RAO, you will see it little bit better. Here the gooseneck is shape is there, which is good. So you see the distance between the device and the moment. Preparation wise, we got a right femoral vein access, one ProGlide is deployed, 7 French sheath wire is there. From the right internal jugular, a TPI is ready to support him. So we are going to open the micra, and Deepchand will show you the preparation of the micra, and then
Ujjwal, it seems to have restarted. Just go to the next, that's fine. So that's as simple as that, the deployments, and basically it takes literally 10 to 15 minutes to do this procedure. It's very, very safe. Now, what if the battery life runs out for these devices? Obviously, the lifetime management for a patient for this micra is, it does have the battery life as much as the normal pacemakers, but you can put sort of 1 or 2 more in the same patient. Go to the next slide, please. Yeah, you can see that this particular patient had 3 devices, and it can be retrieved as well. Go to the next slide, please. As it's shown here, you can take the same steerable sheath, and through the snare, you can hold it and you can retrieve it. Even up to 3 to 4 years, it's been shown that you can retrieve it. Next, please. So both the VR and AV are available for patients who need synchrony. AV is there, and we get about 80 to 90%, and you can reprogram after the procedure is done based on the atrial mechanical contraction, and optimize it. It is a very safe procedure with high success rate. It does provide an alternative to these high-risk patients, and also patients who are at a higher risk of infections, pocket infections, dialysis patients with the poor renal sort of access and other things. The AV algorithm is fantastic, and the newer one is much better in terms of the synchrony. So thank you very much, and thank you for this opportunity, and thank you for all the chairpersons and panelists.
Thank you, Anant. I wanted this also to include in this session because nothing great EP about it. All the interventional cardiologists who can comfortably do this procedure also. Sometimes it helps, especially also settings of recent stents where we have put dual antiplated thugs where they're worried about stopping. There are some scenarios where we have used it, and also renal failure with multiple already fistulas, options gone, and repeat procedures. Thank you, Anantharaman.